Good afternoon. Thank you for the opportunity to speak at this very important gathering. I'm going to commit the crime of trying to report on 4 different studies in a very short period. I can't see the time clock. That's good. Oh, okay, right in front of me. Okay. And we push that. Green, the big one in the middle. Okay, I just want to acknowledge the members of my core team who have been together through most, if not all, of the studies I'm going to tell you about. The context for this body of research, and I should mention that I have been a cancer disparities researcher for the past 30 years. So that is all I do, and that is the context of these studies, but particularly I'm going to be talking about access and communication as the bridge connecting genetic discoveries with the patients who will benefit. I'm pressing the green button. The large green button. Okay. So we've already talked about the fact that currently those with the greatest need have the least opportunity to receive the best care. But I don't think I've heard loudly or clearly enough in this meeting yet the fact that the barriers on this pathway are likely to increase disparities. We're not just looking to decrease them, but precision medicine, if it isn't used equally across all populations, will increase cancer and other health disparities. So the research that we're doing is concentrated in low resource settings. We use inductive and deductive research paradigms. We use qualitative and quantitative methods, and we work with multi-ethnic and multilingual populations. Our purpose is to identify those at high risk for hereditary breast and ovarian cancer, meaning those with a family history suggestive of HBOC, and we work with those who are affected and unaffected with breast cancer in clinic and community settings, and we seek to innovate to improve access to and use of genetic counseling via multiple channels. We want to maximize the effective communication. Effective communication is when 2 parties engage with one another and come away with the same meaning. That is something that must happen in genetic counseling, and I'm going to show you that currently it does not. And this is particularly true with people of low health literacy. And it is critical to understand that fully 1/3 of U.S. adults have low health literacy. We're not talking about a tiny, small minority, although this is disproportionately concentrated among people of non-European heritage. Also, we're working with people of limited English proficiency. So we're trying to maximize effective communication in the most difficult of circumstances, most challenging. Okay, so study number 1 is called Statewide Communication to Reach High-Risk Low SES Women. And this is a partnership that we had with California's Every Woman Counts program. That is a statewide phone service that provides free breast and cervical screening to low-income women. This is one of my key messages. It relates to one of my key messages, which is go where the people are. For this telephone service, thousands of women call in yearly, speaking 18 languages, and they're all low income, and they have to complete an eligibility screener on the phone in order to be referred for free cancer screening. So this is an ideal opportunity and that's the only thing this phone service does. And yet it has this incredible population that they're working with. So we thought, why don't we partner with them to see if we can engage these callers in research to see if they have a strong family history, and if we could actually connect them with genetic counseling. So our interventions that we tested in a randomized controlled trial, where the control group was a delayed control intervention because these are all high-risk women, our interventions were an immediate offer of genetic counseling appointment versus receipt of a brochure with instructions on how to obtain genetic counseling. Our study was in English, Spanish, and I believe Chinese. And English and Spanish, I'm going to say for this one. 709 eligible callers completed our brief family history screener, and that was 58% of the people who were eligible for the study. That's a very high rate of acceptance of participation in research and these are women who were calling to get screening, but we're intercepting that and asking them to participate in research. We created a very parsimonious 6-point family history screener that could be delivered by phone. And that's what we used to identify those at high risk. So we had 99 callers identified as high risk. Our results were that in all, 58% of high-risk women were counseled. Now, of course, I'm making a long story very short, but this is a good result. Significantly more of these were among those who were offered the immediate appointment versus just being sent the brochure. Now, I think of these callers as low-hanging fruit because they were women going to the trouble of calling to get cancer screening. So they're aware of the benefits of cancer screening. They're concerned about cancer. But nonetheless, these are people for whom genetic counseling is not available. Information and education about genetic counseling and genetic risk had not been presented to them. So another thing that we learned in this study is that, and this was just women in the immediate San Francisco Bay Area. We wanted people who could come to our risk program at the Zuckerberg San Francisco General Hospital, where we offer free genetic counseling and testing. And we found that 54% could not attend counseling unless we delivered it by phone. So that was something new for us. We had not been doing phone counseling, but it was either that or nothing for these callers. So this was really about, I call this practice-based research. We went into an existing setting, tried to blend our services as seamlessly as possible with an existing service, not building whole new infrastructure to go out and find these women. So these were all women who would not have gotten these services otherwise. Okay, study number 2 is a very important study led by my colleague, Dr. Galen Joseph, who's an anthropologist at UCSF. She conducted an ethnography of communication between genetic counselors and low-income English, Spanish, and Chinese-speaking patients in the public hospital setting to assess communication effectiveness from the patient's perspective. She did observations and audio recordings of 170 genetic counseling sessions and 65 stimulated recall patient interviews, meaning patients were, segments of the counseling session were replayed to the patient to ask their perceptions about what was going on. And then, based on all of that, I was able, she and I worked together to develop a pilot test training genetic counselors for more effective communication based on the things we learned from the patients. The results very boiled down version, there is a serious mismatch between the information provided by genetic counselors and what the patients wanted and could comprehend, and it was all the more so when interpreters were involved. So genetic counselors are trained to provide a lot of information about what is a gene, what is a mutation, and they are also trained to in informed decision-making. They try very hard not to guide patients one direction or another if they are eligible for testing. I have a huge problem with informed decision-making for low literacy people because nobody has the time and most clinicians don't have the skill, and patients very often want to be guided in what to do. And so I believe wholeheartedly in patient-centered medicine, but we've gone too far in informed decision-making. It's this knee-jerk thing that, oh, we have to do this, and not all patients want or can make use of that. So in terms of the pilot test with genetic counselors, the counselors knew they were not getting through. The same counselors who had been observed were brought together for this training where essentially the issues we worked on were avoiding too much information, using plain talk, and keeping the messages simple, assessing patients for literacy, and importantly, checking comprehension. That if that's the only message that comes through here, clinicians do not check appropriately. They'll say, right? Got any questions? So the genetic counselors knew they weren't getting through to a lot of patients, so they really valued the training. Some of the strategies we worked with them on did prove challenging for them to put into practice, particularly the checking for comprehension. Third study. This is a community-based study we did with African American churches, and I want to quickly add that we didn't just show up at churches one day with this study. I have been working with these churches for over 10 years. The health ministry leaders are my friends, and we really worked hard to build the relationship over time. In that context, and at the request of the health ministry leaders, we did this study on hereditary breast cancer, breast and ovarian cancer. So this was a feasibility study of a culturally tailored education in the churches. We were mainly trying to identify high-risk women and, again, connect them with genetic counseling. We trained health ministry leaders to conduct this workshop. It was not conducted by me or a genetic counselor. Although we started out with some of that, we rapidly went this other direction because we saw that we were not getting through. So we trained health ministry leaders. This was a process of experimentation, assessment, and refinement. We did 41 workshops over 4 years, generated 745 pre-post surveys. In other words, workshop attendees completed a survey of their knowledge of genetic issues pre and post-workshop, and we were able to obtain 729 of our family history screeners. This was our same, what we call our 6-point scale, our parsimonious screener of family history that we had administered by phone in the first study, and here people self-administered paper and pencil. The results were that we were able to successfully refine our key messages in the workshop and showed significant increase in post-workshop knowledge overall on our key HBOC messages. That was really an exciting thing to see because we started out really not doing very well, but we introduced a lot of new messages and educational strategies that really engaged the audience. And so we were able to get the knowledge level up. And overall, we identified 84 high-risk women. 50% of them obtained counseling. Surprisingly, though, we tried out something else because it was the workshops were an enormous amount of effort, and very often the attendance was low. So we decided, let's just try passing out these family history screeners in church on Sunday. And of course, the health ministry leader did this. We didn't do it. The women who only filled out the family history screener at Sunday service were counseled at a higher rate than those who attended the 2-hour workshop. We haven't figured out why that is. We're still analyzing that. Working in the community is not clear or simple. That's a message that one can always take. 1 minute. Okay, study 4 is our current study. I said that we learned from our earlier study that we needed to do telephone counseling to reach a lot of the population. So we developed a study that is comparing. We do not know. Dr. Schwartz said that in his study, telephone counseling, the results of telephone counseling were equal to that of in-person counseling. But we're dealing with a very different population, again, with issues of literacy and cultural differences. And so we are looking to see, we're comparing telephone counseling, in-person counseling, and counseling by video in 3 public hospitals. And we're doing this in English, Chinese, and Spanish. Our target sample of high-risk women will be 540. And in the first 10 months of the intervention, just passing out our screener forms, and you can see we have our Chinese and our English one illustrated there. We got 10,000 completed in 10 months. 634 were potentially high risk, 38% enrolled in the study. 69% of these women were counseled, and 86% completed a follow-up survey. So we're doing very well in reaching, we're going into all kinds of clinics, primary care clinics, oncology clinics, mammography. We're casting a wide net. So I want to say that I think that progress that has been made is that we are understanding issues of reach, trust, and communication. That understanding is really critical. Efficiencies in reach, in other words, getting to the populations, are achievable. But building the trust and communicating effectively are time, money, and labor intensive. There is no 2 ways about it. There's no sexy, easy, high-tech way to achieve those critical things. What's imperative is providing information and services to people where they are with words they understand and messages that are meaningful to them. And the last thing I want to say is the challenges that remain. We've heard about many of them. We need to achieve an educated public with participation from all sectors, again, requiring real investment and a more diverse public health workforce. We also need more diversity among genetic counselors. Last time I checked, it was the least diverse of all the health professions, with only 3% non-white genetic counselors. I'm sure that's changed somewhat, but that has to change. And so I will close there. Thank you.